So let's start. It's 3 o'clock. So let me just introduce what this Jaipur Surgical School is. Actually, this is a new online educational initiative of our institution, the Mahatma Gandhi Medical College Hospital. We were already running a Jaipur Surgical tutorial where we conduct a class on Saturday morning, 9 to 10. But a lot of colleagues, especially from Africa, they said that they can't join because it is an odd time for them. So we started this Friday afternoon session. The target audience is mainly surgical residents and practicing surgeons. Normally, we cover surgical topics, but I feel that it is very important for surgical residents and surgeons to know the related specialities also. So in that context, I requested my colleague, Dr. Anushri. Anushri, you can put your video on, camera on. You can come in. She is an associate professor of radiation oncology at the Mahatma Gandhi Medical College Hospital with me in Jaipur. I requested her to cover the topic of principles of radiation therapy, and I am very happy that my former colleague, Dr. Shalin Kumar, who is the chief of radiotherapy at SCPGI in Lucknow, a very prestigious institution where I also worked. Shalin, am I audible? Anushri says that she can't hear me.
You're audible to me, sir.
So I'm very happy and thank you, Dr. Shalin, for agreeing to moderate this session. So I'll now request Anushri to please proceed with her presentation.
So, good afternoon, everyone. Am I audible?
Yes, please.
So today I'm going to discuss the principles of radiation therapy. At the outset, I would like to clarify that this presentation is meant for a broad audience who do not have knowledge of radiation oncology. So the flow of the presentation will be what is radiation and radiation therapy, its radiobiology, the types of radiation therapy, its indication, and the entire process. So first we'll discuss what is radiation and radiation therapy. So there are three pillars of cancer treatment: surgery, chemotherapy, and radiotherapy. So whenever we hear the name radiotherapy, there are some misconceptions that need to be addressed, that it is not shock therapy, it is not current, it is not light, and it does not lead to burn. So what is radiotherapy? It is also known as radiation therapy or radiation oncology, and it is the medical use of ionizing radiation as a part of cancer treatment to control the malignant cells. And the dose that we prescribe is usually defined in terms of gray. That is, whenever we say that patient has to be given this much dose, it is said like in CA rectum we give 50.4 gray, which is equal to the amount of energy that is absorbed per unit mass. So, as already discussed, it is the use of ionizing radiation. So, what is radiation? We know there are various forms of energy, like kinetic energy, potential energy. Likewise, radiation is also a form of energy, and it is basically of two types. One is ionizing radiation, that is the ability to remove electron from an atom, and the other is non-ionizing, something concept which is familiar to us all, that radiation has dual nature. We have read it in our physics that radiation has electromagnetic nature as well as particulate nature. So this is the very familiar electromagnetic spectrum. On the one end of it is the non-ionizing radiation, which are low energy, low frequency waves and are seen in our day-to-day life, like radio waves, microwaves, visible rays. And as the energy increases, it becomes ionizing, like the ones used in diagnostic X-rays and the gamma rays. Then the other nature is explained by the particle theory, that is the energy, it has both energy as well as mass, and they are capable of causing ionization. Example are alpha particles, beta particles, neutrons, as well as protons. Now, where do we get this radiation from? So it exists either naturally, example are the solar radiation, or from radioactive materials like radium, uranium. And we can also produce this radiation artificially, like from the X-ray machines, from our linear accelerators, and even in nuclear reactors, we can make radioactive materials by neutron bombardment. So, if we describe in simple words, these are nothing but high energy rays, usually in megavolts. They are more penetrating and they have the ability to kill cancer cells. And each ionizing radiation has its unique property, which can be used in the treatment of a particular type of cancer. Now we'll discuss the radiobiology and the basis of fractionation. So, how does radiation act? So, radiation, we know that inside a cell is the nucleus which contains chromosomes, and chromosome is nothing but coiled DNA with some associated proteins. So, this DNA is the main target of radiation. So, radiation acts by two ways. One is indirect action, and other is a direct action. So the main action mode of action is indirect action, which is occurs in two-thirds of the cases. What happens here is when the radiation enters inside the body, it reacts with oxygen, which is readily available. Reacting with the water, it forms free radical, and this free radical then attaches to the DNA strand and causes the damage. When the free radical attaches to DNA, oxygen is also required for that process. So in oxic cells, this kind of damage occurs. The other mode of action is direct action, where the radiation directly damages the DNA strands. It occurs in around one-third of the cases. So the damage to the DNA strand can be either single strand break, that is only the one strand is damaged, and in such cases the damage can be repaired because we have a template strand for the damage to repair. So if we give some time, the damage can be repaired. While in some cases where especially in particulate radiation, the damage caused is to both the strands, and if such a damage occurs, it leads to permanent cell kill. So most of the cells are in G0 phase, and whenever a cells decide to divide, it enters the G1 phase and GS phase, where it produces cell material for the cell division. And whenever it has to divide, it goes into the G2 and the M phase. So in this is the particular phase of the cell cycle where cell is most prone to radiation induced damage. So G2M is the most radiosensitive phase of cell kill. And this can also be seen in this flow chart where actively dividing cells, they are more radiosensitive, while least dividing cell or the senescent cell, they are less radiosensitive. If we see the treatment that of radiation, it is usually given as a fractionated treatment. That is, the entire dose is spread out over a period of time, usually 5 to 7 weeks in case of radical cases, and for shorter duration in palliative cases. And we rarely give it in single fraction, and mostly given 5 days a week and 2 days off. So, what is the basis of dividing the dose in small fraction? That is explained by its the 6 R's of radiobiology. So, we'll discuss what are the R's of radiobiology. So, first is DNA repair. What happens is, as we have already discussed, that the single strand break can be repaired easily if given some time. However, double strand breaks cannot be repaired. So the DNA repair mechanism is more proficient in the normal cells. So whenever we give some time between two fraction of radiation, the normal tissues are able to repair themselves more than the tumor cells. So there is more tumor cell kill and less of normal tissue damage. The other R is redistribution. That if we give first fraction where the cells are in G1 S phase, they might not get killed. However, as they progress into the cell cycle during the next fraction, they might be into G to M phase, which is more radiosensitive. So when we give the next fraction and they are in G2M phase, they get killed. The third R is repopulation. That once we give radiation, the cells that are left behind this start to divide again and start growing. So repeatedly giving radiation leads to cell kill. The fourth R is reoxygenation. That is, we have seen the indirect action, it requires oxygen for its action. So, if in the oxic cells, the radiation acts well. So, if there is a large tumor, the periphery is vascularized, however, the center is hypoxic. Once the cell gets killed and the tumor shrinks in size, the center also gets oxygen from the blood vessels and they become radiosensitive. And the fifth R is intrinsic radiosensitivity, which is patient specific and tumor specific. So, this is the reason why we give it in daily fractions. The third thing that we'll discuss is the types of radiation therapy. So, radiation can be classified on the basis of source of radiation, intent of treatment, and the technique of treatment. The first, on the basis of source of radiation, first is teletherapy, when the source of radiation is outside the body. Examples when we treat with photons, electrons, and particles like proton beam therapy or carbon ion therapy. The other is brachytherapy, when the radioactive source is placed inside or near the body, and it can be classified as intracavitary, interstitial, surface mold, intraluminal, and radioembolization. Examples of intracavitary is when we use in carcinoma of cervix, interstitial is carcinoma of breast, surface molds are nose or hard palate, intraluminal is like carcinoma of esophagus, and radioembolization in hepatocellular carcinoma. And we can use low contact X-rays like in carcinoma of rectum. And the third type is radiopharmaceuticals, which is mainly dealt by the nuclear medicine people. Here it is the sources that is given is unsealed sources, and the radioisotopes are usually given either orally or through IV, and they have affinity for a particular tissue. And the radiation that is released is either in the form of alpha or beta particles, and mostly they are used in the treatment of bone pain or in thyroid cancer or polycythemia vera. The other classification of radiotherapy is on the basis of intent of treatment. It can be classified as neoadjuvant, adjuvant, radical, prophylactic, or palliative. So, what is neoadjuvant therapy? So when radiation precedes surgery, that is before, when it is given before surgery, it is called pre-op RT or neoadjuvant RT, and its main aim is to downstage or reduce the tumor size. And mostly it is used in carcinoma of esophagus, carcinoma of rectum, in soft tissue sarcomas for limb preservation. Then the next is radical radiotherapy, where we use high doses of radiation to cure the cancer, and it is also used as organ sparing approach, and mostly it is given concurrently with chemotherapy. So its examples are carcinoma cervix, in carcinoma larynx, carcinoma urinary bladder, it can be used as organ sparing approach. Then the third is adjuvant RT, when it is given after surgery, and the main aim is to kill the microscopic cells. Example is when we give in breast cancer, oral cavity carcinoma after surgery, then it is called adjuvant radiotherapy. The fourth type is prophylactic radiotherapy, that is radiation which is given to a particular site in the absence of any gross disease. Example, we give cranial irradiation to leukemia patient where the chemotherapy is not able to cross the blood-brain barrier to treat the sanctuary sites. And the fifth type is palliative radiotherapy, where it is given with an intent to alleviate the symptoms of a patient like bone pain, spinal cord compression, or SVC or bleeding. Now, radiation can also be classified on the basis of treatment technique. The first type is conventional radiotherapy. So, if we see the treatment head of a linear accelerator or a cobalt machine, these are the collimator jaws which open and define the field size. So these collimator jaws, they either open in the form of a square or rectangle. And whenever we have to treat a tumor tissue, the surrounding normal tissue, it gets a similar amount of radiation as that of cancer. So we are not able to spare the normal organs in 2D techniques unless and until we use some blocks. The next type is 3D conformal radiotherapy. So, as already discussed, below these collimator jaws, there is another apparatus that is fixed in 3D CRT, which are called MLCs. These are nothing but metallic leaves which are capable of moving independently, and they conform to the shape of the tumor. So, with this, we can spare the normal tissue to some extent. The next is intensity modulated radiotherapy. Here, the organ sparing is more than 3D CRT because what happens here is the beam is divided into small beamlets. So in IMRT, we are able to modulate the intensity of all these small beamlets, and therefore there is more organ sparing. Also, if we can increase the intensity in a particular area, we can give more dose of radiation to a particular area as compared to the other sites. So this is IMRT. So in some cases like thoracic or upper abdominal malignancy where the our target is not static, motion management is also required. Like in this case, if we do not apply any motion management technique, then this will be our volume, and it will lead to irradiation of large amount of normal tissues. However, these are the techniques we can use to reduce the normal tissue toxicity and to target only the tumor. So, various techniques have been defined. Now, whether we plan with 3D CRT or with IMRT, we can use image guidance before treatment delivery or at the time of during treatment delivery to see whether whatever we have planned it is going to that area only, and whether it also helps us in knowing whether there are any anatomic variation during the course of treatment, like patient if they have weight loss we can check with our CBCTs, or if there is tumor regression we can do adaptive planning. Then there are techniques like SRS, stereotactic radiotherapy, or stereotactic body um, radiation therapy, or stereotactic radiosurgery, where we are able to deliver very high doses of radiation to the tumor and with least radiation to the surrounding normal tissue. So when it is used in brain cases and only a single dose is given, it is called stereotactic radiosurgery. If it is spread out over several doses, then it is called fractionated radiosurgery. And in sites other than brain, when it is given, the term SBRT is used, or SABR, stereotactic ablative radiotherapy, is used. Proton beam therapy. So until now, what we have discussed, we were using photon as a part of treatment. In proton, the difference is that beyond the tumor cells, the exit dose, the protons, the exit dose of protons is very minimal or near to nil. So the side effects are very less. However, the photons, they do not stop after delivering radiation to the tumor, and so there is normal tissue toxicity more with photons as compared to protons. Now, what are the various equipments for teletherapy? So first is cobalt 60 teletherapy machine. So here in the head lies the cobalt 60 source, which decays into nickel, and gamma rays are emitted. The other is linear accelerator, where artificially the X-rays are produced by accelerating the electrons, and when they hit the target, X-rays are produced. Gamma knife, here multiple around 192 to 201 cobalt sources are used and mainly used for cranial SRS and SRTs. Cyber knife, which is a linear accelerator, is mounted in this small robotic arm, and it is useful for treating the cranial as well as extracranial diseases. Proton beam therapy, which uses proton particle therapy for the treatment, and ZEP surgical, which is also used for cranial tumors, but here the also the X-rays are used for the treatment. These are the facilities which are available at Mahatma Gandhi Hospital. We have two linear accelerators, TrueBeam and Unique, a dedicated CT simulator, and a brachytherapy machine with iridium source. Next, what are the indications of radiotherapy? So radiation is used in around 70% of all the cases of oncology, and its indication ranges from curation to palliation, from benign cases to malignant, and from pediatric to geriatric cases. And in almost all the sites can be treated with radiotherapy and have shown good results. So, what is the process of radiation therapy? So basically, it is a teamwork of radiation oncologist, dosimetrist and physicist, and radiation therapist. So radiation oncologist is a doctor who gives specializes in using radiation. Dosimetrist and physicist, they decide the dose and the technique, and they make the plan. And radiation therapist, he or she carries out the treatment on the machine. So this is the process. First, we select the patient in multidisciplinary settings and we decide which patient will require radiotherapy. So, after a patient has been selected, the first process is simulation. So, what we do in simulation is we first immobilize the patient so that the patient does not move during the treatment. So there are various ways of immobilization, like we can use a thermoplastic mold, we can use backlock, we can use stereotactic body frames. After immobilizing the patient with the same immobilization technique, we do a CT scan. So CT scan is done of the target area with or without IV contrast depending on the site of disease, and this CT, it serves as a reference image for our planning purpose. So like this patient, CT scan was done with this immobilization device in the treatment position. So this is the position patient is required to maintain during the entire course of treatment. So after simulation has been done and we acquire these CT images, these images are then transferred to the treatment planning system where we delineate the target and the tissues. So we have got specialized computers where these images are transferred, known as the planning systems. So first, as we delineate the target as per the standard guidelines, and for delineation of the target, we made this like this in red is our target volume. Along with that, we take some areas of microscopic spread, which is the CTV, known as CTV in pink, and to we give some margin to it depending on our institutional protocol to account for any setup error, which is shown in blue. So this entire blue area will be our total planning target volume. For better delineation, we can take the help of MRI as well as PET scan. After the target has been delineated, we need to save the normal organs, nearby structures also, because our main aim of radiation is to cure the cancer as well as to have a better quality of life. Okay, so we delineate the normal organ at risk after delineation of the target, and even for sometimes for the delineation of the organ at risk, we may need some additional imaging. Like in this patient, we wanted to give SBRT to this spinal mat. So the dose was around 24 gray in 2 fraction, which is very high dose per fraction. So here our main organ at risk is spinal cord. And for delineation of spinal cord, we took the help of MRI. So it is not only the tumor, but also sometimes a normal organ at risk require imaging for better delineation. The next step after we have done our contouring and everything, we give it to the physicist for treatment planning and optimization, and then we do the plan evaluation. So treatment planning mostly earlier were done, it was blind and surface marking was used. Then came the era of X-rays, we used X-rays, and now mostly in most of the cases, we are doing CT based planning. So the technique and dose is decided by the radiation oncologist, that we need to treat this tumor with this technique and this much dose, and the beam angles and energy is decided by the physicist. So like in this case, we did a 11 field IMRT plan, and with today's technique, we are able to spare the spinal cord. Here, the dose that it received was 14 gray and the tolerance is 17 gray. So we were able to achieve what we wanted to with today's technique. After the plan has been evaluated that it is fine, the patient can be treated with this plan, but we need to check whether the machine parameters are normal or not. So the phases do a daily, weekly, or monthly quality assurance, and after all the parameters are fine, treatment is delivered. So once the patient is taken on machine for treatment, we do onboard imaging. So what is onboard imaging? It is acquiring either a X-ray or CT scan before imaging to check whether what patient the volumes that we wish to treat are in the correct position or not. And once we have done accurate matching, then only we deliver the radiation. So our job does not end here. We have to assess the toxicity. So acute toxicity is assessed weekly. So every patient who is on RT is assessed weekly or on SOS basis. And acute toxicity, it lasts up to 3 months. And on follow-up, we assess the late toxicities, which is usually 6 months and after. So these are the kind of toxicities like with today's IMRT techniques, fatigue and nausea are more common. And depending on the site we are treating, the toxicity may occur like dermatitis, mucositis for head and neck patients, diarrhea for GI patients or pelvic patients receiving pelvic radiotherapy, cystitis, radiation enteritis, and late toxicities like fibrosis, proctitis, cystitis, infertility, and second malignancies. And however, we can reduce these toxicities with modern techniques of radiation. And the last step is follow-up, which is usually done 3 months after the completion of radiation in cases of radical radiotherapy, 4 to 6 weeks after neoadjuvant treatment, and we do it with clinical evaluation or imaging. If imaging is used, we use RECIST or PERSIST criteria depending on the imaging that we are using. And usually the follow-up protocol is like we do it every 3 months for the first 2 years, then every 6 months for the next 3 years, and then yearly. Thank you.
Yeah. Shalin?
It's a very comprehensive coverage, and look forward to questions from the audience.
Yeah, while they are coming up, maybe you can add something.
Okay. I would think that Dr. Anushri has done a very good job. Dr. Anushri, would you mind sharing your slides on radio sensitivity? Would that be possible for you to show those slides?
Yes, sir. This one?
Yes, this one. Right. So the refinement that one proposes is not proposes the addition to what has already been explained. It's important to know that those tissues that are going through the cycle of mitosis are the ones where you will see manifestations.
I think we lost connection with Dr. Shalin. So, Anushri.
As Dr. Anushri explained, that if there is damage to the DNA, then at mitosis, you've had duplication of chromosomes, and then through the centromeres, equal quantities of DNA sort of go to both the daughter nuclei. If there is unequal complement of DNA, that's when the daughter cell is rendered non-viable and may undergo apoptosis. And there is involution. So by way of example, if one is receiving radiation to the buccal mucosa or the intestine, the time that it takes for the cells from the basal layer to come to the surface of the mucosa, or let us say from the basal layer to come to the surface of the villus. Now that is practically 2 days. So if I give radiation today to the gut, or you will find that you can have diarrhea in practically 2 or 3 days. However, for instance, if the radiation is given to the skin, then right from the stratum basale, where you have the Malpighian corpuscles and the granular cell layer, right up to stratum lucidum, corneum, the superficial layer, there are 4 or 5 distinct layers. They take about, depending upon the type of skin, may take up to about 2 to 3 weeks. So when you give radiation today, it will take while the reproduction is stopped in the basal layer, but there are mature cells in the intermediate layers, and so the injury is not manifest. It is only when they've shed off and there is no replacement from below that you manifest injury. So we tend to think that those that manifest a response are more radiosensitive, and those that don't apparently manifest a response are radioresistant. And a classic example,
We are losing him in between.
the multiplication. So if cells are not multiplying, they will not have a response. You will not be able to see a response. So in theory, neurons don't respond. They do not multiply. But the injury, for instance, happens in the capillary endothelium supplying blood and the astrocytes, the glue. They have generation times of 3 months to 6 months. And so the injury comes later because the supportive element is gone, although the nerve hasn't really multiplied. But this doesn't mean that the nerves are not radiosensitive. It's just it's just a refinement over what Dr. Anushri explained. But it's important to know that if the summary is, if in the manner we understand it, it doesn't mean you can pump radiation indefinitely. And therefore, this is one of the important differences we must understand. That was, I thought, something that could be explained to colleagues in other disciplines that we do.
So, Anushri, from the point of view of a surgeon, may I ask you, because many of the surgical students and even teachers, they are not sure of these various terms which you use, IGRT, IMRT, confocal radiotherapy. Can you briefly explain what these variations are?
Yes, sir.
Maybe you covered it, but in between I had to receive an administrative call, so maybe I didn't pay attention to it. Anushri, we are not able to hear you.
Hello.
Yes, now we can hear you. We had lost
Yes.
connection in between.
So this is conventional radiotherapy. This is the head of the linear accelerator, and these are the jaws through which radiation comes out. So if we can see the magnified view, it can open in the form of a rectangle or a square. So whenever we open the field, it will deliver the same amount of radiation to our target volume as well as the normal tissue. So we are not able to spare our normal tissues. We can put some blocks, but the sparing is not that much. In 3D conformal radiotherapy, below those collimator jaws will be present in all the machines. We can use machine has inbuilt multi-leaf collimators. These are nothing but small metallic leaves which have the ability to move independent of each other, and they can conform to the shape of our target. So with this, we can spare our normal tissue to some extent and give radiation only to the tumor. The next is intensity modulated radiation therapy. Here, likewise in 3D CRT, we use MLCs to shape our beam. But what happens is when the radiation comes out, it is divided into small beamlets. The entire beam is divided in like this grid into small beamlets. So in this beamlet, we can modulate the intensity. Like one beamlet will be of 10 strength, the other will be of 5 strength, example. So we can push more dose to a particular part of cancer and less dose to the other sites where we think the tumor cells are less. So this is intensity modulated. Like in a part, we can give different doses of radiation, and there is better sparing of the normal tissues with IMRT. And IGRT is nothing, but we can plan with either 3D CRT or IMRT. But it is the use of imaging on the treatment machine. On the machine, we can use either ultrasonography or X-rays, or some machines have inbuilt X-ray or CT scan facility. So after we place the patient, we take a scan and just check it whether the patient is lying in the same position that we did the our CT planning, and if there is any motion, internal motion due to bladder filling or rectal filling, or even during the course of treatment, we can with the help of CT scan, we can check whether the patient has lost any weight or is there is any regression of the tumor, and we can do replanning in such patients. Then SRS SBRT is use of high dose of radiation per fraction. So mostly it is used for cranial or extracranial sites. When we use it for cranial sites, it is called as stereotactic radiosurgery if we are giving it in a single fraction. If we are fractionating it in 3 to 5 fraction, it is called fractionated stereotactic radiotherapy. If we are using high dose of radiation in sites other than CNS, then it is called stereotactic body radiotherapy, or SABR, stereotactic ablative radiotherapy. Then proton beam therapy, it uses proton for the treatment, and the quality of proton is that they deposit the entire dose to the tumor. So the exit dose beyond the tumor, the tissues get very little or negligible doses. While in photons, they do not stop after giving a dose to the tumor, and they have got some exit dose. So there is more damage to the tissue beyond the tumor with photons as compared to protons.
The other clinical dilemma which we face is, suppose there is a squamous cell carcinoma of the esophagus, and we refer the
Sorry,
patient
sir, you
for
are inaudible. Just
uh,
wait.
there is a clinical dilemma. Shaleen, sometimes we face this issue that we have referred a patient for neoadjuvant chemoradiotherapy to you, and the patient shows good response. Patient is clinically better, and although we had planned surgery, but now the patient says that because I am better, I don't want surgery, give me the complete radiation dose. But obviously there has been a gap. So what to do in such a situation? Because the dose for neoadjuvant versus radical or definitive chemoradiotherapy for CA esophagus probably would be different, isn't it? So how do we handle this situation?
Would you like me to take this, or Dr.
Yes,
Anushri?
please.
No?
I think I don't know whether Anushri could hear me or not.
But I think Dr. Anushri can have a go if she likes, and then.
Anu, could you hear the question?
Yes, so when we assess for surgery after neoadjuvant treatment, it is usually given after we assess after 4 to 6 weeks. So whenever we assess for surgery after neoadjuvant radiotherapy, it is usually done at 4 to 6 weeks. And at that time, there is no point in giving the remaining dose of radiation, because if we give a treatment gap of more than 5 to 7 days, we have to adjust for the time that has lapsed. And after 4 to 6 weeks, there will be just normal tissue toxicity that will be giving, and will not be achieving what we desire to achieve. So in such cases, if patient has clinical complete response and does not wish to undergo surgery, we just keep on observation and regular follow-up.
So what is important from our surgical point of view is that upfront we have to decide whether we are planning to give neoadjuvant treatment or definitive treatment. Can you please, for the students' sake, tell us that how much radiation you give if it is neoadjuvant, and how much you give if it is definitive for squamous cell carcinoma, say, of the mid or upper esophagus?
For carcinoma esophagus, if we are giving neoadjuvant treatment, then we give a dose of 41.4 gray in 23 fractions. And if we are giving radical treatment, at present, the data says there is no point in giving doses more than 50 gray. However, we are still giving 54 gray at present, 54 gray in 30 fractions to such patients.
Okay. Another question is when we have a large colonic tumor, right or left, and it is bleeding. So earlier we used to say that we will always have to go in and do even a palliative resection. So can you please tell us what is the role of radiation in controlling bleeding from a colo or colorectal cancer, and what is the schedule and how much is the dose?
Um, so for hemostatic RT, the doses and schedules, they are not very standardized. So it varies from institution to institution. We usually give around 20 gray in 5 fractions or 16 gray 4 fractions, depending how the patient responds. But these are not very standardized doses that we can give. So
But
everyone has their different protocols.
yeah, but each dose is more than the usual dose, and it is a short course.
Yes,
Yes,
sir.
sir.
So if a surgical student says that, that is good enough. He may not know the exact dose and duration. The third question is about bone metastasis, palliation.
Yes, sir. So for bone metastasis, it
Yes.
depends whether the mets is associated with any soft tissue mass or it is just bony mets. And what is the prognosis of the patient? If the patient is going to survive more than 6 months, then we go for around 2 week course of radiation, because the pain control with a single fraction and multiple fraction is same. Like if we give 8 gray single fraction or 30 gray in 10 fraction, the pain control is same. However, the chances that the patient will have pain again is less with fractionated course. That is, if we give 30 gray in 10 fraction. For patient with very poor prognosis, we usually give 8 gray single fraction. For patient with good prognosis, we or oligometastatic, we may give even SBRT.
But even a single dose would palliate the pain to great extent.
Yes, sir. Except if it is associated with soft tissue mass, there we usually give fractionated.
There is a question from Dr. Salumu Ahmada from Africa in the chat. Can you please take it? I
Yes, sir.
will read the question for the others' benefit. So there is a child of 13 years with rhabdomyosarcoma who underwent a above knee amputation 1 month ago, and now he has a swollen stump with distended vessels, and X-rays show metastasis to lung. So what about radiosensitivity of a rhabdomyosarcoma? How to handle this?
So, rhabdomyosarcomas, they are radiosensitive tumors, and radiation is a part of their standard part of treatment. So, what it is a metastatic case, the protocol for treatment would be different. So, usually, what happens is first we give chemotherapy, and then after a course of chemotherapy, radiation is given. In patients who have localized disease, we give radiation to the site. In protocols, even for lung metastasis, radiation to whole lung is also given.
Okay, so we have a few minutes. Maybe I would request Dr. Shaleen to make some concluding remarks and statements. But before that, Anushri told me, Shaleen, that you were her external examiner for her MD radiotherapy exam. So I said that the examiner may or may not remember, but it is good to have both student and teacher as speaker and moderator. So Shaleen, your concluding remarks.
So, nothing really. Dr. Anushri has done a wonderful job, without an iota of doubt. And the reason is that she's covered enormous breadth of the subject, and I would not add. Maybe just now, in response to the two questions we asked about esophagus and about the bone mets, it is true that we started the protocol for organ preservation. No, rather the pre-op protocol in our place. We started with 45 gray, and we used to give single agent cisplatin, and then we graduated to carboxol, and after the cross protocol which she alluded to, and the dose is lower, and the drugs, there are two drugs there. And it is correct that you give that and you stop, regardless of the bulk of disease. Because something that's more bulky and not likely to be operated, I completely agree with her that the evidence now, randomized evidence, suggests that 50 gray is about the limit with chemotherapy, and it should be done upfront. In other words, at at the time when the treatment is over, and if you were sort of in a dilemma as to whether to be operating or not, normally we would want to wait for about a week, 10 days, 15 days before we did a CT scan to see whether there was a response, because response always lags behind the the treatment for the reasons that we just discussed. But to the extent possible, it should be possible to decide sooner rather than later what is what, and complete 50 gray. If you complete 50 gray, so what people have suggested now is that if you give this dose, I mean, I don't know how it works out, but they're looking at the fact that, even in the cross protocol, there were 50% of patients with pathological complete response. And in theory, they could be followed up. So, as you said, the patient doesn't want treatment after a pre-op course of radiotherapy. If it's a squamous carcinoma, uh, half of them would have actually, well, depending upon disease type and size, we can't extrapolate the data from the West. The tumors were much smaller than the sort of tumors we see. I mean, you can't talk about a tumor that is 8 or 10 centimeters with a lot of nodal burden. That would not be representative of the clinical that we talk about. But if the tumors are slightly smaller, typically about, between 4 to 6 centimeters length, that is about roughly 30-40% of our load. Most have much more bigger lengths. So half of those would have a pathological CR. So if the patient doesn't want, you can observe. The question, of course, is whether you should top it up to 50 gray. After a while, there's no point doing it. We should try and do it sooner rather than later. That was the comment about that. As far as the bone mets is concerned, it is true that the pain response is identical for the single fraction and 6 week and the more protracted fraction, as Dr. Anushri mentioned. However, when you look at the meta-analysis and the conclusions that they have, they say that the reason for giving a second course of radiation after the first is based more on perception of physicians, of treating doctors, that perhaps enough dose was not given. And that is the reason why they get retreated, not because of any scientific value. The proportion of patients who have pain relief is identical. The time to sustenance is also identical. Duration of relief is identical in randomized evidence and in meta-analysis. However, the fact that pain has come back and the threshold for ordering a retreatment is lower in the case of single fraction, in the perception that there is additional tolerance left or you can try it again. But what Dr. Anushri said, that if you have soft tissue masses there, you need to make sure that they involute. If there's a soft tissue mass, for instance, spinal cord, this, that, and the other, and the patient has good prognosis. The important words she talked about was expected longevity, prognosis of patient, disease burden. And so that is what decides. And the oligometastatic story is now there, that it is possible to, ablate with precision radiation and higher doses in 1 or 2 or 3 fractions these sites of disease, metastatic disease in bone and elsewhere. And but they are a select group of patients. And we also have immunotherapy coming in. And there was the 6th hour of radiotherapy that she mentioned there. But that was, of course, a refinement. So with this there, the story about metastasis has taken a slight shift. We still need to know whether it makes a difference. It probably does, but these are select group of patients, in any case, who have a better prognosis. So, Dr. Anushri, would you like to refine that, or would you kind of agree with the bone story, or would you think it differently?
No, sir.
I mean, I'm done. So we have some time left, or it's 4 o'clock now. So I leave you, let you decide, sir,
Yes.
how you'd like to take it further.
Okay, so I think I would like to thank Anushri for, as Dr. Shaleen said, a very comprehensive coverage of principles of radiotherapy. I think if a surgical student writes even half of what Anushri has spoken, he or she will pass in the MS General Surgery exam. And that was the intent, that all surgical students should know the basic principles of radiotherapy. And thank you, Dr. Shaleen, for accepting my request to moderate this session. Thank you very much. Thanks to all the attendees. I must inform the speaker and the moderator that although the number of delegates who join live is small, but as you would see in the next few days, the views of the uploaded videos are very good. So all these presentations are seen by surgical residents and surgical students at a later date. Thank you very much. We will
Thank
close
you,
this
sir.
session. Thank you. Thank you.
Thank you, sir. Thank you, Shalin, sir.